Good morning everyone. Today I'll be presenting a unique case on waxing and waning pattern of choroidal granulomas. So basically the choroidal granulomas can arise either from the infectious or non-infectious causes, which making accurate diagnosis essential due to its different therapeutic approaches. The three main granulomatous conditions kept in the mind during diagnosis of choroidal granuloma mainly includes VKH disease, sarcoidosis and tuberculosis. So why accurate diagnosis matters, as misdiagnosis may lead to inappropriate therapy like administering corticosteroids in presumed VKH when TB is actual etiology may result in systemic dissemination of infection. So the aim of our case was to present a unique case showing waxing and waning pattern of choroidal granuloma. A 28-year-old previously healthy female presented to ophthalmology department with chief complaint of both had diminution of vision since 4 months, which was associated with mild pain and redness in both the eyes. There was also history of dyspnea on exertion 6 months back, which was associated with fever, weight and appetite loss. So on further examination, the best corrected visual acuity in the right eye was 6.9, in the left eye was 6.18. The intraocular pressure by mean of non-contact tonometer in the right eye was 12 and in the left eye was 11 mmHg. Left eye lids show swelling, and in both the conjunctival congestion, circumcorneal congestion was present. The cornea in both eyes show mutton fat capes which were present inferiorly. AC reaction of +1 was seen in both the eyes along with vitritis of +2 grade. The fundus in the right eye showed media clarity grade 2 and the disc was normal size, normal shape, margins were clear, cup disc ratio of 0.2, fovea reflex was present, the blood vessels were within normal limit but were seen hazily, patches of choroiditis was seen, and in the left eye, disc showed disc edema along with the presence of multiple granulomas. So on further investigations, fundus autofluorescence show hyperautofluorescence with surrounding hypoautofluorescence at granuloma sites. Fluorescein angiography showed multiple pinpoint leaks and dye pooling. On further OCT showed multiple pigment epithelial detachments along with serous retinal detachment as seen in above picture. So in OCT picture we can see that there is a large granuloma. On further systematic investigations were done which showed angiotensin levels were mildly elevated. Montox was found to be negative. Zn stain was negative for acid-fast bacilli. The chest X-ray and CT were within normal limit. No pulmonary infiltrates were seen. So based on the bilateral granulomatous uveitis, serous retinal detachment, bacillary layer detachment, absence of infectious signs, a diagnosis of incomplete VKH disease was established. So after starting patient on oral steroids, oral and topical steroids, OCT showed complete disappearance after 2 days of posterior pole granulomas that were present initially. This spontaneous remission highlights the unpredictable nature of VKH. So the key differential which were kept in mind were VKH disease, sarcoidosis and tuberculosis. A VKH disease is always bilateral and the granuloma type is non-caseating diffuse, and OCT finding we can see bacillary layer detachment, which and the systemic signs includes vitiligo, tinnitus, alopecia, and they respond well to corticosteroids. Further, the differential that were kept into mind was sarcoidosis. It can be bilateral or unilateral. The granulomas involved are non-caseating granulomas. On OCT finding, we can see choroidal thickening and choroidal nodules, which is associated with hilar lymphadenopathy and respond well to steroid along with immunosuppressants. Now coming to the tuberculosis, the granuloma type is caseating non-granuloma, differentiating it from the sarcoidosis. The OCT findings show a dome-shaped mass, which is associated with systemic features like fever, cough, weight loss, and respond well to antitubercular drugs. So based on this, the diagnosis of the incomplete VKH disease was made. So the patient was started on systemic corticosteroids plus topical steroids and cycloplegic. Rapid improvement in the visual acuity and resolution of subretinal fluid and granuloma was seen. No relapse was further noted, and the steroids were further tapered under close monitoring. Talking about the weakage disease now, it primarily affects pigmented individual. It's a bilateral granulomatous panuveitis which is associated with serious retinal detachment, and you can present with a neurologic and cutaneous manifestation. The diagnostic criteria is of international classification, which is further divided into definitive and probable diagnosis and incomplete weakage. So now coming to the take-home message, the choroidal granuloma represents a common manifestation among different inflammatory and infectious diseases. So this case highlights the diagnostic value of multimodal imaging in identifying key features such as blood, PEDs and subretinal sepsis which favor weakage diagnosis. The things taken into consideration were multimodal imaging of OCT and FFA, providing a diagnostic information for the differentiation, and timely diagnosis and management lead to the vision preservation in our case. The systemic clinical evaluation combined with the target investigation is the key for the diagnosis of the weakage and the timely management. Thank you.
So any questions for Dr. Bagla? Any questions? Thank you.
Thank you.
So our next presenter is Dr. Nitish Arora, and his topic is reconstruction of ocular surface in post-chemical injury and ophthalmic socket.
Please remove those standby CH and all. We can't read the material on the screen.
Screen के नीचे ना?
Screen का नीचे में जो standby volume source वो पूरा material hide कर रहा है.
Old gentleman who came to my OPD for getting prosthetic eye change. History of acid attack in 2015, and he took treatment for same elsewhere, underwent multiple surgeries, and this was the condition when he presented to me. So in this case, you can see scarring of the upper lid, you can see ill-fitted stock eye, there is a purulent discharge. On seeing without the COP, patient had scarring and ptosis of the upper lid. There is lash ptosis with lid margin notching. There is lower lid ectropion grade 4. On seeing the inner surface, you can notice a scarring in the upper lid margin with symblepharon formation, centrally placed PMMA implant, scarring of the medial canthal structures with loss of puncta, and lower lid ectropion. So the diagnosis of right eye trauma with ACID and ophthalmic socket with centrally placed well-covered implant with lower lid ectropion with upper lid notch and multiple symblepharon was made. So what is contracted socket? A contracted socket is dreaded complication of enophthalmos which leads to shortening of onysis, ultimately leading to an inability to retain a prosthesis. Appropriate clinical care is essential, and adequate prosthesis wear gives confidence and quality of life to an ophthalmic patient. So socket contraction may be due to poor previous surgical technique, early removal of the conformer positioned at the time of surgery, incorrect wearing of the prosthesis, recurrent socket inflammation, previous external beam radiotherapy, immunological diseases like SJS, and chemical or thermal trauma, which was in our case. So pathogenesis of socket contraction goes back to activity of myofibroblast. Tawfiq et al. Have explained that a single injection of MMC, triamcinolone or 5-fluorouracil or bevacizumab reduces the number of myofibroblasts, reducing the tendency of socket contraction. Gopal Krishna classification was a very unique grading system which was based on the phonesis, depending upon the upper, superior, inferior, loss of phonesis and involvement of all the four phonesis. But it was upgraded classification by Tawfiq et al., which was based on the contraction, how much contraction is there. So our case fits into grade 3, which is advanced scarring with impossibility to wear prosthesis. So according to the system of contracted socket, we should go for volume deficit first and then think about the contraction. But in our case, there was no volume deficit. There was mild contraction in the upper and lower socket. So socket molders or entropion or ectropion correction has to be done. The goal of the management is to reform the scarred fornix and excision of all the symblephra so that reepithelialization occurs and increase conjunctival surface so that the prosthesis can be easily fit. In grade 1 and 2, use of specially designed progressively large conformers and upper and lower eyelid ectropion and tropion correction should be done. And in grade 2 and 3 contraction, fornices may be deepened by positioning of autologous spacers. MMG is useful for moist sockets, skin for dry sockets, and AMG has been suggested as an alternative in cases of mild grade of socket contracture. So our plan was to make lower fornix deeper. So lower lid FFS, that is fornix formation suture with ectropion correction was done in the first sitting, which was followed by surface reconstruction and symblepharon release in the second sitting. So after fornix formation suture, this was the condition of the patient. There was a good lower fornix which was formed, and patient was able to close the eye, and the conformer, you can see it is well fitted in the lower fornix. But the problem was still there. There was a upper symblepharon formation. So a patient was planned for a symblepharon release with the AMG graft, and this was the condition after that. And after sufficient space is formed, patient was planned for a COP, and you can see patient was in a very better condition, and he was not concerned about the lower lid entropion which was occurring now. But so this is the pre-op picture and the post-op picture. So my take-home message in this case would be the presentation of a contracted socket can be extremely variable, and management always tailored made according to the specific needs of the patient. And management of contracted socket is based on two important findings. First is severity and location of the symblepharon, and second is the amount of residual or vital volume. Thank you.
Thank you, Dr.
Which type of suture do you use for fornix formation?
Fornix formation, I usually use silk.
Which one?
40 silk.
20 silk could be better?
20 silk can be, it is more thicker. I prefer using 40 silk.
Thank you, Dr. Nitish.
So I'll be presenting a case of a unilateral acute angle closure with rosette cataract with serious detachments, a diagnostic dilemma. So, it's not moving. Sorry. So we had a patient, a 43-year-old male who came with complaints of sudden blurring of vision and on and off pain in the right eye since 3 days. There was no history of trauma. There was history of over-the-counter drug intake 5 days back, but the details were not available. There was no history of wearing glasses. Recent documents reported emetropia. There was no history of any systemic illness. So on examination, the right eye had an unaided vision of 618, which was correcting to 6.6 with an acute myopic shift of -3 diopters. The cornea was clear, AC was shallow, gonioscopy showed Schaffer grade 2, so all the angles were closed. Pupil was sluggishly reacting to light, and in the undilated state, the lens appeared clear, and the intraocular pressure was 24 mm Hg, and the left eye anterior segment appeared normal. So this is the right eye ASOCT showing the shallow AC and the iris lens diaphragm pushed anteriorly. So here at this stage, our differentials could be, one is it could be a secondary angle closure due to ciliary body effusion or anterior rotation of the lens iris diaphragm. But this is usually seen in drug-induced cases, uveal effusion or inflammatory causes. So this could explain the myopic shift, angle closure and increased IOP. Then the other could have been a lens-induced cause, like there is a traumatic anterior subluxation of the lens, spherophakia, that could also lead to myopic shift with angle narrowing. However, there was no history of any trauma. Or it could be a primary angle closure, but this is usually seen in hyperopes. But here also the acute myopic shift suggests a secondary mechanism. Or it could be a uveal effusion or idiopathic ciliary body edema, medication or toxin induced, in which there is classically a bilateral myopic shift. So the key clues in this case were, so the age is younger than a typical primary angle closure, and there was an acute -3 diopter myopic shift, which strongly points to a ciliary body edema or an effusion related mechanism rather than primary angle closure. And the IOP was 24, which is not very high, as in an acute attack of primary angle closure, further suggesting some secondary angle closure with effusion rather than pupillary block. So seeing these things in mind, we narrowed our diagnosis to probably a primary uveal effusion or secondary to maybe the drug which he had taken. So we started the patient on topical steroids aqueous suppressants, and cycloplegics. However, the patient came back next day with intense pain and an intraocular pressure of 30 millimeters of mercury. So now the patient was dilated under the effect of the cycloplegic. So we could see a temporal rosette-like cataract in the right eye, and also the right eye fundus image showed multiple, which was confirmed on OCT. It showed multiple serous retinal detachments with choroidal folds. So now the evolving differentials could be, one is again the uveal effusion syndrome or the cilio-choroidal effusion, which again explains the myopic shift, the secondary angle closure, serous detachments, choroidal folds. It can be seen idiopathically or in nanophthalmos or drug induced. The other possibility could be a VKH spectrum disease. However, it could be an early or atypical presentation, because normally there is bilateral serous RDs, choroidal folds, but it may start unilaterally. And the inflammatory pathology could be the cause for the IOP rise. So then again, we revisited the history and a detailed drug history was taken. Again, we just know that he had taken some drugs 5 days back over the counter, but we don't know what it was. Then the systemic review for VKH was done, that is headache, tinnitus, integumentary changes, but there was none. The axial length biometry was normal, so it ruled out nanophthalmos. However, the FFA showed multiple pinpoint leaks with pooling. So a probable diagnosis of unilateral probable VKH was made, and the patient was given intravenous methylprednisolone 1 gram for 3 days, followed by oral steroids. So here we can see the serial OCT showing a resolution of the serous detachments. The vision was restored to 6/6 unaided. The IOP came under control, and the AC normal depth. So the anterior segment OCT showing the deepening of the anterior chamber. So here basically so in this case it presented multiple things we could see in this case. However, detailed history and effective imaging modalities helped us come to a diagnosis. However, there were still some things which would not answered, like the partial rosette cataract, which maybe it could be because of the inflammatory pathology, and there was no history of trauma. So yeah, thank you. Presentation, but yeah, other eye was completely normal. Yes, yes. Yeah, all the routine systemic investigations for uveitis was done. All that was again negative. It was all normal. No, yeah, we repeatedly asked, but there was no history of. So it could probably be an incidental finding, or it was related to this case. I mean, we still couldn't make out. Thank you.
Thank you, Dr. From trauma to treatment, managing blood rupture. Not here. Dr. Supreet Rai.
So it was a 34-year-old female from Bathinda. She complained of profuse watering and sudden diminution of vision in left eye since 1 day, and then had blunt trauma previously on that day itself. She also had mild pain. She was a known case of bilateral pigmentary glaucoma, had bilateral cataract surgery and bilateral trabeculectomy in the past. The findings of the right eye were normal. In the left eye, the patient presented with hand movements vision, and the eye was very soft to touch. The intraocular pressure on examination was 4 mmHg, and anterior chamber was flat. And obviously the pupil was fixed dilated, sorry. On presentation, this is the clinical picture of the patient, which showed that the patient had ruptured blebs at the superior limbus, also had a flat anterior chamber, had a fixed dilated pupil. This is the anterior segment OCT of the same picture, in which the transscleral fistula can be seen, through which whole of the aqueous was draining out. Sedals of the patient was positive, the anterior chamber was flat, and there was iridocorneal touch. On posterior segment examination, the choroidals were present. So how did we manage it? We did a left eye scleral patch graft with conjunctival advancement, in which the bandage lens was applied post-operatively along with antibiotic and steroid coverage, topical, Also, cycloplegic drugs were given, and systemic antibiotic cover was also given to the patient. After 15 days of follow-up, patient presented with very low IOP and CDLS was slightly positive. So we applied cyanoacrylate glue at the site of scleral patch grafting to maintain the anterior chamber, as the anterior chamber was well formed at this presentation, as we can see in the picture. 3 months post-operatively, status post-glue removal. This was the picture of the patient. The anterior chamber was well formed and intraocular pressure was maintained at 9. So this is the picture 3 months post-operatively. The patient had a good vision, 6/9 she was maintaining, and she did not have any complaints as such. So what we conclude out of this is that scleral patch graft with conjunctival advancement was the definitive management to be done for blood leak due to scleral fistula, averting potential catastrophic consequences. It not only restores the ocular integrity but also visually rehabilitates the eye. The patient now needs regular monitoring for wound leaks, IOP spikes, and may need glaucoma filtration surgery in the future. Thank you so much.
Looks with glue rather than applying a patch, a scleral patch, because there is a potential risk of rejection of scleral patch.
So, sir, there was a perforation present, which was quite, it was not a small one. It was around 2 to 3 mm. Basically, the bleb was ruptured. So, we preferred applying a patch rather than the glue straight away.
Is there any guideline when to use patch graft, when to use glue?
Yes, ma'am, it depends on the size of the perforation.
What is that?
It is, ma'am, 2 mm. If it is more than that, then 3 mm. If it is more than that, then we need to do the patch grafting.
Thank you.
Thank you.
Everyone. Today's topic is limbal dermoid cyst in pediatric patient, a case report examining diagnosis, management, and surgical intervention of congenital ocular surface lesion in 9-year-old patient. It is a benign congenital choriostoma composed of ectodermal and mesodermal elements, typically present at inferotemporal limbus, and it is slow-growing, non-progressive. Clinical significance in pediatric patients, it affects the vision, like it induces astigmatism, it causes a surface irritation, and may be of cosmetic concern. Case presentation, a 9-year-old male child with well-defined and non-progressive swelling in the inferotemporal limbus right eye was noticed with no inflammation and no other symptom. Main concern was cosmetic. On examination, eyebrows, eyelids, eyelashes are normal. Conjunctiva is clear and healthy. Cornea is also clear. Pupillary reaction is normal and reactive. Extraocular movements are full and free. Visual acuity 6/6 both eye. No sign of inflammation, and fundus was also within normal limit. The characteristics of the lesion, it is firm to palpate, slightly raised above the surface, yellowish white appearance. There is no sign of inflammation, and it is non-progressive in nature. Differentials are Goldenhar syndrome. We referred the patient to ENT and orthosurgeon to rule out the Goldenhar syndrome. And they rule out the Goldenhar as there was no preauricular tags or any vertebral disformities. Then a surgery was planned, complete excision was done under the general anesthesia, and the tissues were sent to the histopath lab. This is the sample. On histopathology, it shows the cyst cavity lined by stratified squamous epithelium with keratin flakes and fibrovascular tissues with congested and dilated blood vessels, and shows sebaceous gland and hair follicles. Postoperatively, we kept the patient for 24 hours and discharged in satisfied condition. 100% complete excision with no complication and 24-hour stay. Early recognition can prevent the progression and complications like astigmatism, and it will correct the aesthetic purpose of the patient also. Long-term sequelae prevention can be done if we intervene early
as it induces astigmatism, cosmetic disfigurement, ocular surface irritation, and visual development. Management principles. We should do thorough clinical assessment and do early intervention and collaborate with other specialities to rule out the syndromes. In pediatric cases, we should give special attention to development impact, like it will prevent amblyopia and refractive errors. According to literature, 95% is the success rate, less than 5% is the complication rate, and 85% is the cosmetic satisfaction of the patient. Take-home messages: we should intervene early to avoid the complications. Thank you.
How do you reconstruct the ocular surface after removing the limbal dermoid?
We just suture the conjunctiva.
That's all. If their deficit is much larger, in that case, what else would you like to do?
Graft.
Which graft?
Corneal graft. If we occupies the corneal area.
AMT can be used if the
Yes, ma'am.
conjunctival
Yes, ma'am.
deficit is more.
I'm not taking
And then if what you are talking about, then it becomes a corneal case. You need to involve the cornea specialist as well, whether that site is perforated depending upon how much thickness. Generally, it doesn't happen. Lamellar keratectomy is enough.
It is less than 2 mm. No, ma'am, it's not done. Actually, the child was not cooperative at that time. Thank you.
Thank you, Dr. Manjot. So our next lecture is aphakic glaucoma, a case report by Dr. Mayanka.
Good morning, everyone. I am Dr. Mayanka Saini, junior resident from GMC Amritsar. I'll be presenting a case of aphakic glaucoma. Understanding aphakic glaucoma. Aphakic glaucoma in adults can develop in the following intracapsular cataract extraction, complicated extracapsular surgery, or ocular trauma. This condition may manifest anywhere from months to over 40 years post-surgery, often presenting long after initial surgical details become unavailable. Primary risk factors include post-op inflammation, shallow anterior chamber depth, retained lens matter, high axial length measurements, pathological myopia. It can be angle closure or open angle. In angle closure, the reasons can be pupillary block from vitreous or inflammatory membranes, peripheral anterior synecdoche with chronic synechial closure, forward iris vitreous displacement due to reducing aqueous outflow. Open angle include trabecular meshwork damage or underdeveloped steroid-induced outflow resistance and lens particle or ghost cell obstruction. Patient profile. 68-year-old male presented with the chief complaints of gradual progressive painless diminution of vision, intermittent ocular discomfort. No significant systemic history was included, but the cataract surgery for this patient was performed in his 20s. No surgical details were available. The visual acuity was 660 in both the eyes, best corrected to 612 in the right eye and 618 in the left eye. The patient was using +10 diopter aphakic glasses. The intraocular pressure was noted to be in the 40s, more than 40 mostly, in the left eye, and in the right eye it was normal. In the anterior segment, the right eye showed vitreous strands and aphakia. In the left eye there was aphakia, and old pigmented KPs as seen in the picture were seen. Vitreous strands were present. Posterior segment showed a cup disc ratio of 0.9 in the left eye with nasalization, and on gonio, pigmented trabecular meshwork with peripheral anterior synecdoche in all quadrants in both eyes. OCT RNFL revealed advanced thinning pattern in the left eye, as you can see in the image. The right eye was mostly all green. In the B scan it was normal. The retina was on. Both the eyes showed an axial length of more than 26 mm. So how did we differentiate this from uveitic glaucoma? So the points supporting aphakic glaucoma were clear surgical history of cataract extraction at young age, absence of active inflammatory signs, bilateral aphakic state with structural changes in both eyes, chronic course without acute exacerbations, persistent IOP elevation, peripheral anterior synecdoche were broad, consistent with post-surgical changes. against uveitic glaucoma, no history of systemic inflammatory conditions, absence of cells and flares in the AC, no posterior synecdoche or iris nodules, keratic precipitates were old and pigmented, not fresh inflammatory, no active inflammation, IOP pattern not fluctuating, and usually it was persistently high despite absence of active inflammation. The clinical presentation timeline and examination findings strongly support the diagnosis of aphakic glaucoma secondary to surgical complications rather than primary uveitic pathology. The patient was started on oral acetazolamide and syrup glycerol for immediate reduction of IOP, and on subsequent visit, brimonidine, timolol, dorzolamide were added. And since the IOP was still not under control, we used Repasudil to increase the outflow, again to no benefit. Despite maximal tolerated medical therapy, IOP remained inadequately controlled, necessitating surgical intervention. Trabeculectomy with vitomycin C 2 mg per ml was done due to proven efficacy in aphakic glaucoma. Post-op, the patient was started on prednisolone, moxifloxacin, and lubricating eye drops. The current status is that the left eye is showing good surgical response and the right is being closely monitored for potential development of glaucoma. This image shows the bleb in the first image, and the second shows the surgical iridectomy that was done. Indiana bleb grading was used to classify this. The bleb was of medium height, making it H2. It was 3 cloacas, making it E2. And the vascularity was moderate, V3, and the sedals was negative, there was no leak. Clinical discussion and outcomes. Key learning points. Aphakic glaucoma can present decades after initial surgery. Differentiating from uveitic glaucoma requires careful clinical assessment. Early surgical intervention may prevent further optic nerve damage. Long-term follow-up is essential for both operated and fellow eyes. Advanced presentation and significant optic nerve damage were the challenges. Multiple medication resistance, bilateral involvement necessitating careful monitoring. This case demonstrated the importance of recognizing aphakic glaucoma as a distinct clinical entity requiring prompt and appropriate management. The successful differentiation from uveitic glaucoma and timely surgical intervention with trabeculectomy represents the current standard of care for medically uncontrolled cases. Thank you.
Thank you, Dr. Menga. And this topic is a spectrum of 2 cases of foveal hypoplasia.
Good morning all. I would like to thank AIOS for giving me this opportunity to address your August gathering. I can't see my slides, please. Yes, so I'll be presenting on a spectrum of 2 cases of foveal hypoplasia. Foveal hypoplasia is absence or poor definition of the foveal pit at center of macula, commonly associated with albinism, aniridia, achromatopsia, microphthalmia, nystagmus, and ROP. Fovea plana is basically an absence of a foveal pit, but the foveal cone specialization is preserved anatomically and functionally with a good visual prognosis. It was suggested by Marmer et al. Optic disc pit occurs due to the failure of closure of embryonic fissure. It's a type of congenital cavitatory anomaly. Other anomalies include extrapapillary cavitation, optic disc coloboma, and a morning glory syndrome. So it's basically a solitary ovoid gray-white excavation in the inferiotemporal quadrant, about 1/4 of the disc size. 25 to 75% of these cases will develop an ODPM at some stage in their life. So our first case, a 12-year-old girl presented with complaints of decreased vision in the left eye since 5 years. There was no significant medical or ocular history, no preterm birth. The best corrected visual acuity in the left eye with was 636 with -3 diopters, and the axial length was 23.5 mm. The slit lamp examination, anterior segment was normal with notably no transillumination defects, no nystagmus. The fundus was normal with no albinotic features, but the fovea had an ill-defined maculofoveal area. On the autofluorescence, a normal FAZ is seen in the right eye, while the left shows a smaller FAZ. The right eye OCT was normal, while the left eye showed persistence of the inner retinal layers, absence of foveal pit in the foveolar area. While the second case, this 14-year-old girl came with the complaints of decreased vision in both eyes since 1 year. Again, there was no significant medical or ocular history, no preterm birth. The right eye, she was 6'9" with +3.5 diopters. The axial length was around 20 mm. Anterior segment was normal with notable no transillumination defects of iris, no nystagmus, no albinotic fundus. The optic disc had a pit in both eyes. The fovea showed an altered FR in the right eye. Fundus photos showing a vitreous veil, optic disc pit temporally in both eyes, and an altered FR in the right eye. On autofluorescence, the FAZ is again smaller as compared to the left eye. The right eye OCT again showing an absence of foveal pit with persistence of the inner retinal layers. The cone widening is present, outer nuclear layer widening is present. So it was a grade 2 foveal hypoplasia. The left eye was normal. We followed up after 6 months. She maintained the visual acuity with the similar diagnosis. So foveal development starts about 14 to 22 weeks of gestation, continues till about 13 years of age. There's first an outward displacement of the inner retinal layers, followed by cone photoreceptor specialization, followed by inward migration of the photoreceptors. So there's a single layer of cones by 20 to 22 weeks. By 25 weeks, there's an outward displacement of ganglion cells, inner plexiform and inner nuclear layer, which forms the foveal pit, followed by growth and length of the cone inner segments by 29 weeks. The foveal pit appears completely by 15 months, and the cone density continues to increase till about 13 years of age. So foveal hypoplasia occurs when the foveal pit either fails to develop during any one of the 3 stages. It may be associated with a poor visual acuity, also may be associated with nystagmus. Can be seen associated with PARC6 anomalies, SLC3888 anomaly, FRMD7 anomaly. This was graded on OCT by Thomas et al., a normal OCT as we all know. On stage 1A, there is extrusion of the plexiform layers. 1B, extrusion of the layers with a shallow foveal pit. On 2, the foveal pit is absent. In stage 3, the cone widening is absent. And stage 4, outer nuclear layer widening is also absent. Atypical when these features are associated with some drusen or PED anomalies. So this case was reported in a 9-year-old boy, ill-defined maculofoveal area with a less delineated foveal reflex. The left eye showed absence of foveal pit, and as the classification by Thomas, it was again grade 2. Before this, these cases were not reported. Only 3 had been described before this report, all with varying degrees of vision loss. It has been reported with albinism. As can be seen, the foveal contour is not noted on OCT. In patients with aniridia with PA6 anomaly, the foveal contour is absent. In posterior microphthalmos, again, foveal pit is absent. In ROP, it can be seen post-laser. While optic disc pit, the incidence is about 1 in 11,000. It's bilateral in about 15% of cases. The various differentials needs to be differentiated from ONH hypoplasia, morning glory syndrome, and coloboma. It has been reported with Aicardi syndrome, Algale syndrome, bilateral renal hypoplasia, bilateral keratoconus, but there's no reported case of ODP with unilateral foveaplasia. This was a nearly similar case, but there was septo-optic dysplasia with fovea plana. The foveal contour is absent. Grade 2, as identified by the OCT classification, decreased visual acuity was due to optic nerve hypoplasia. Another ophthalmic image was published which showed an optic nerve head pit with sectoral inner retinal hypoplasia. So to summarize, my first case had unilateral foveaplasia, hypoplasia with decreased vision, about which few case reports exist. Second case had good visual acuity, but it has not been reported before. Multimodal imaging helps in the diagnosis. We published our first case in DJO. The second is under publication. Thank you.
So then our next lecture is ocular syphilis by Dr. Anshu Kapoor. It's not here. We move on to the next lecture. This case presentation, ocular injury due to a KMNO4 by Dr. Verleen Kaur.
Good morning, everyone. I'll be presenting a rare case of chemical injury that was a KMNO4 injury in a child. A 7-year-old girl presented to us with extreme pain and blackish pigmentation in her left eye. After systemic examination by the pediatrics department, the child was referred to eye emergency. Brown colored staining was observed on the face and palate, so ENT opinion was taken, but it revealed no evidence of ingestion of any substance. There was some solid material spilled inside the eye, as we can see in the image. On inquiry, parents revealed that the child was playing in the backyard and where they have kept some chemical to stain the bird wings. When they noticed her screaming of pain, that packet was in her hand. On further inquiry, they showed that packet and it was confirmed to be potassium permanganate. The child was uncooperative due to severe pain, so we used topical anesthesia for immediate lavage and assessment of extent of damage. Consistent with the standard treatment guidelines, copious irrigation was done with 4000 ml of normal saline. The pH indicator was not present with us, so pH level could not be checked after irrigation. These are the images after copious washing on the day of presentation. On fluorescein staining, a full limbus to limbus epithelial defect was seen. The limbus was also swollen lazily and there was conjunctival chemosis. All the granules were delicately removed and the surface was irrigated again. The patient was then started on mild steroids, antibiotics, preservative-free artificial tears, 5% dipanthenol eye ointment and oral vitamin C tablet. The parents were advised admission but they refused. This shows the images from day 2 of presentation. Now some ischemic changes had set in. On day 3, the vision was 6/9 and a membrane was observed in the inferior fornix. So the child was sedated and adhesions were lysed with swab sticks and ointment. There was excoriation of eyelid skin. A conformer was placed into the eye to prevent symblepharon formation, as we can see in the second image. These are the images from day 4 and day 5 of presentation. The child was then started on autologous serum eye drops. On day 6, there was some evidence of membrane formation in the inferior fornix. Day 12, the membrane was still present. Ischemic changes were present. Corneal epithelial haze was present. So the patient was planned for amniotic membrane grafting. This is the status post-amniotic membrane grafting. Now we were prepared to start eye drop losartan, but it was kept for later stages. On day 22, we saw an epithelial defect on fluorescein staining. Day 33, there was symblepharon formation that was grade B according to the width of symblepharon. So the patient was planned not only for symblepharon release, but conjunctival autografting from the other eye. Releasing the adhesions, which is important to look into the subconjunctival area, preparing the limbal graft, securing 1 centimeter limbal stem cells, and finally suturing onto the defect. Ensure that the fornices are well pushed into. This would then be followed by a bandage contact lens and conformer, and the other eye defect will be sutured. So day 40, that is day 5 post symblepharon release, fornix ring was present and BCL was in place. Day 50, that is day 15 post symblepharon release, vision was 6/12 improving to 6/9, fornix ring was removed and BCL was replaced. Day 65 of presentation and day 30 post symblepharon release, vision has improved to 6/7.5, sutures were intact and healthy, cornea was clear and inferior fornix was formed and deep. 3 months post presentation, there is no evidence of symblepharon, vision is 6/9 improving to 6/7.5, inferior fornix is deep and cornea is clear. The child is still under follow-up. So conclusion, chemical injury can cause n number of complications affecting the lid, globe or even glaucoma. Mainstay of treatment is early and timely intervention. KMNO4, according to its chemical properties, can burn human tissue and it can cause coagulative necrosis. Our patient fell under grade 4 according to Dua's classification and grade 3 according to the Ropohol classification. Vitamin C and steroids play a major role in controlling inflammation and also used in cicatrizing insults like chemical injury. The patient is still kept under close follow-up. So community education is also equally important in such cases. Thank you.
Dr. Ulin, I think I will like to use not mild steroid in first 5 to 7 days, full strength steroids to so that inflammation is subside and for better healing. For first 5 to 7 days, then you can taper and reduce it. Thank you, Dr. Ulin. So our next presenter is Dr. Navdeep Kaur. The topic is diagnostic dilemma of orbital cellulitis. Okay. Okay, okay. So in the meantime, Dr. Tanya Modgil or Dr. Anshu Kapoor? Not here. हाँ, अभी तो नहीं है, वेट फॉर जब तक वो आ जाता है।
Good morning, everyone. I'm presenting a case on diagnostic dilemma of orbital cellulitis. A 3-year-old male patient presented in IOPD with chief complaint of severe eye pain in right eye. It was associated with lid swelling and inability to open the eyes. Patient presented with assured skin on the affected area with underlying necrotic tissue. His parents gave the history of foreign body in right eye 3 days ago. He was taken to local hospital. No insect or any other foreign body was seen. He was treated for lid swelling with topical antibiotic and anti-inflammatory treatment. His condition got worsened and he was not able to open his eye on presentation in ROPD. On examination, vision of the right eye cannot be assessed. In the left eye also it cannot be assessed as the patient was 3 years old. Extraocular movements cannot be assessed. In the lids, necros skin of lid was present, and left eye was lids, conjunctiva, cornea, iris, anterior chamber all were within the normal limit. On contrast enhanced MRI, a small T1, T2 hypointense focus in the upper lid was present, query foreign body, swelling of right preseptal and perizygomatic soft tissue with fat stranding, no obvious intracranial extension of collection, high TLC count, rest was within normal limit, and so plan of management was examination under anesthesia. Patient was taken into OT under short GA, eye examination was done, and to our surprise an insect was extracted from the lower fornix. Voriconazole wash was done, debridement of scarred and necrosed tissue from lids were done. Insect was sent for microbiological examination. It was found out to be Tachyporus obtusus. On examination, superficial corneal haze was present. Infiltrates were present inferiorly. Circumcorneal congestion was present. He was treated with lubricants, topical steroids, and Netamet, Vigamox, and eye ointment Penthagel. And IV antibiotics, vancomycin and ceftriaxone was also started. This was a picture of the post-op day 1, day 2 and day 3. It was great to see the patient's sunshine smiles on the day 2 post-op. 1 week post-op, the healing process of the scar tissue was complicated by the presence of membrane. And 2 weeks post-op, the patient demonstrated a favorable healing response with no evidence of membrane. On examination, vision in the right eye was 612 and left eye was 66. Inferior bands of infiltrates were present. 2 weeks post-operatively, the patient demonstrated a favorable healing response with no evidence of membrane. On examination, right eye 612 and inferior bands were present. We are happy to report that the patient's orbital cellulitis was fully resolved at 3 weeks and with follow-up vision of 6/6 in the right eye. So take-home message is examination under anesthesia is a necessary diagnostic tool for uncooperative patients, enabling us to conduct a thorough assessment. This case underscores the need for timely recognition and treatment to prevent the onset of orbital cellulitis and its associated complications. Thank you.
Thank you, Doctor. So, two presenter, Dr. Anshu Kapoor or Dr. Tanya Modgil? Not here? So that is the end of this session. To conclude this session, thank you for being here. Doctor, ये बाकी लगा इनको पकड़ाना कहाँ है? I will request our presenter to be here for a group photograph.